Hello, everyone. Thank you for joining us. I'm Bettina Shell Duncan. I'm a biomedical anthropologist at the University of Washington. And for the past 5 years, I've had the honor and pleasure of being a member of the Population Council coordinated and African-led research consortium called Evidence to End FGM Research to Help Girls and Women Thrive. 5 years ago, with generous funding and input from UK's Department for International Development, we were able to launch a research initiative to generate evidence on the issue of FGMC with the aim of advancing theories of change and optimizing efforts to accelerate the abandonment of FGMC. This program has spanned 7 countries and produced a wealth of evidence on when, where, and why FGMC is practiced and how abandonment can be understood through theories of change and how interventions might become more optimized and targeted. Today, I would like to welcome you to the first part of a 2-part webinar. The second of our webinars will be held 1 week from tomorrow. That's Friday, May 22nd at 4 o'clock East African time. If you've not registered for that webinar, we would like to invite you to please register. Today's presentation is entitled Improving Health and Legal Systems Framework for the Response to FGMC. We will have a series of short presentations, and at the end of these presentations, at the end of the series of the presentations, we will have a period of time for questions and answers. I invite you to submit your questions throughout the presentation in the chat box, and I will organize them based on the speaker and the theme, and pose these questions at the end of the session. And as Chantal mentioned, at the end of today's webinar, we'll have a number of materials available, a link to all of the reports and publications that have come out of this consortium, a link to today's PowerPoint presentation, and also a recording of this webinar. So today, our first speaker, I'm pleased to introduce Dr. Jacinta Muteshi-Strun. Jacinta Muteshi is a renowned expert on gender inequality and human rights and reproductive health. Her extensive and diverse career experiences, which include serving as the first chair of the National Committee on Gender and Development in Kenya, and as the director of the board of the Kenya Human Rights Commission, are united by the common goal of addressing unequal outcomes for girls and women. And for the past 5 years, she has masterfully directed the Populations Council Multi-Country Research Consortium and FGMC. Welcome, Jacinta.
Thank you very much, Bettina. Thank you. I would like to begin by first appreciating and thanking each one of you for joining us on this webinar discussion, and for the insights and contributions you have all been providing over the last 5 years of this FGMC research program. The research program concludes this month. And as Bettina highlighted, we began 5 years ago. DFID launched this initiative to support a robust research program, to build a body of ethical and rigorous evidence that would support efforts to end FGMC. Those efforts have been particularly geared towards strengthening or informing programs, policies, investments that would support abandonment. And we've been led by a vision of ending FGMC in 1 generation. It's important to note that the research has been undertaken under the guidance of Population Council, and it's been a research consortium inclusive of NGOs, universities, individuals, and experts in the various fields, and across 8 African countries. So as we have worked, we have been very much guided by an understanding of this issue as gendered, socially endorsed harmful practice, as a form of gender-based violence and as violation of rights of women and girls. So what I'd like to do very briefly in the few minutes I have is to highlight what our research themes have been, some of the emerging evidence, but very briefly around those themes, and some closing thoughts on moving forward. Next slide. So the research has been guided by 4 broad themes. The first theme has been around building the picture. The second theme has been around interventions. The third theme speaks to what are the wider impacts of FGMC and its interventions. And the fourth theme or thematic area has been around measurement. Within each of these themes, there have been several research projects. So for example, around building the picture, we developed several projects that sought to understand where, when, and why is FGMC practiced, and also is it changing and where is it changing? And the evidence emerging from here has continued to highlight the need to be specific or to recognize the specificity of the work and therefore the responses that emerge. Around interventions, we've sought to ask what is working, where, and why. Around what are the wider impacts of the interventions. These studies have been very diverse, looking at whether there are associations, for example, between early and forced marriage and FGMC, fistula and FGMC, and also whether there's consequences around women's sexuality with FGMC. And the fourth broad thematic area has been the area around measurement. Measurement centrally put on that diagram, as you can see, because issues of measurement have emerged as we built the picture, as we looked at interventions and as we looked at wider impacts. But ultimately, we're seeking to understand what would be valid measures of social change? How do we improve measurement so that we can in fact track change when it happens? How can we improve how we collect data that informs the decisions that get made around where do we work, where do interventions need to occur? Next slide. So some of the emerging evidence, just to highlight, is when we looked at building a rigorous evidence base on how FGMC is practiced and how the practice has evolved and is continuing to evolve, several things emerge that we provide robust evidence. Changes in the age of cutting, and just very quickly to mention here that changes in the age of cutting varies even across nation states. We're seeing the increasing significance of medicalized FGMC, shifting narratives and norms, how communities and individuals talk about FGMC, the norms that underpin FGMC, that those are also shifting and changing. The complex nature of power and decision-making around the practice. There's often been an assumption that this is women's business, but we know that it isn't, because those who make decisions, yes, in some communities it is women. In others, it's actually older women who make these decisions. In others, they've become joint family decisions as a response to changing norms or as a response to changing influences by either government or interventions that are happening. And also one of the things we have noted across much of the work that historically and continuing to happen is the absence of men and boys around planned abandonment interventions. And lastly, around how it's changing are the structural responses around FGMC. Here it's important to highlight that when we speak of noting the changes, the structural changes that are occurring, we're speaking here about how families respond, one, to structural changes such as changes in law. Families respond to whether they cut or don't cut their daughters, or whether the practice becomes invisible around the practices of law, as we shall hear later on in the presentations to follow. But also structural responses can be economic changes. Economic changes have consequences to whether parents continue to cut their daughters or do not cut their daughters. And we'll talk a little bit more about those as well. Next slide. Other highlights that have emerged have been that we've illuminated the variations and complexities of local realities, both within countries and also between countries, which means that strategies or interventions cannot be standards. Some very powerful examples have emerged out of the work in rural and poor South Senegalese families, who we found worry about securing the future of their daughters and ensuring entry of their daughters into social support systems in a context of economic and climatic instability, among other concerns. So what does this suggest about what type of intervention would we need to be considering in such a context where families cut so that they ensure or secure the welfare of their daughters? Or in Burkina Faso, where Burkina Faso presents us with the best practice example of law implementation since 1996. And we've seen therefore drops in prevalence in Burkina Faso, but yet we've also begun to see with our evidence that there are families who continue to cut, but cross the border into Mali where there is no law. So these are important emerging pieces of evidence around the complexities and variations in the practice. Next slide, please. When we looked at trying to understand the nature of prevalence across global prevalence, those numbers have been well presented by our partners such as the UN Joint Program and UNICEF. But we looked specifically at 3 priority countries, Kenya, Nigeria, and Senegal, to begin to understand what does prevalence look like in those 3 countries. And what is highlighted in our evidence is that it's going to be increasingly important to focus on subnational level data. Subnational level data enables you to begin to see sort of the hotspot areas where populations remain higher at risk than others. A good example is Kenya, where Kenya national prevalence is at 21%, which has shown a steady drop over time. And yet there are communities in Kenya where we know, given this kind of analysis that it looks at subnational data, there are communities where we still have universal prevalence. So with this type of data, but particularly the subnational level data or hotspots data, is very useful data for health practitioners and policymakers, because it is enabling a much deeper understanding of the geography and the pattern of FGMC, so that you can better target investment and efforts where most needed. Next slide. So I want to conclude by saying, when we think of how we move forward with these very brief highlights that I've made, consistently, and this many of us in the work know, FGMC practices continue to serve a valued societal behavior, seen as a valued societal behavior. There are means by which families assure their daughters access to social assets. So consequently, we know they're being upheld by multiple and diverse social and gender norms. Thus, social and behavior change interventions must begin to think about how they address a whole schema of cultural values and norms, because as I've said, with this need to pay attention to the specificity of the practice and the regions and its manifestations. So a whole schema of cultural values and norms underpin this practice. They're not the same across regions or across communities. That inequalities also, we have to pay attention to inequalities in the sense that it is not just about inequalities between women and men, but even the inequalities that exist within nations across communities, and the consequences that might have with regards to whether some communities continue to see FGMC as the only way in which they access social assets. And any social and behavior change interventions must begin to address, or must be thinking about, how does the community have ownership of these ideas around changing or ending or supporting the abandonment of the practice. And thus, these interventions clearly we're beginning to note, and we've shared in much of the evidence we've generated, are about utilizing data, because data sheds light on the complexities that underpin the practice. It's about utilizing high quality evidence as basis of your responses, as basis of the interventions that are being imagined or thought. And lastly, that it will be about utilizing collaborative multi-sectoral approaches beyond targeting isolated behaviors and isolated individuals. And those multi-sectoral approaches increasingly look like having interventions that pay attention to health, education, the economy, as well as law. Thank you very much.
Thank you very much, Jacinta. We are going to take questions at the end and try to keep on track on our time schedule. With that, I'm going to very quickly go into introducing our next speaker, Dr. Agnes Maroka Mutua, who is a senior lecturer at the University of Nairobi School of Law, where she teaches on law and development, gender and law, human rights law, and disability law. She is a member of the technical working group on the accountability and monitoring of the African Partnership to End Violence Against Children. And she was the principal investigator for the Kenya-based study on the role of law in reducing FGMC, and coordinated with a comparative study in Mali and Burkina Faso that was led by Dr. Josephine Wango. Welcome, Agnes.
Bettina, we seem to have problem with Agnes, so maybe we move to the next speaker.
Let's go to Kimani. I will introduce Dr. Samuel Kimani, who is a nurse and a senior lecturer at the School of Nursing at the University of Nairobi, and is a member of the African Coordinating Center for the Abandonment of FGMC. He has extensive expertise on the health impacts of FGMC. He has worked on curricular training materials for medical providers, and he has studied the effects of FGMC on sexual functioning. In our consortium, he led a number of studies. He led a Kenya-based study on drivers of medicalisation in Kenya. With me, he co-authored a critical review of debates surrounding medicalisation, and he was also the PI of a study on the role of health systems in responding to and preventing FGMC. This was a comparative study along with Nigeria that was led by Dr. Otiwo Obiamu. Welcome, Kimani.
Thank you, Bettina, and welcome. I welcome every member. I wish to present a research we conducted on diagnostic assessment of health system response to female genital mutilation, prevention and management. And this work is collaborative between Kenyan team and also the Nigerian team. Next. Now, health systems can actually respond to FGM through two pathways. One is prevention of FGM, and also responding to complications that are suffered by women and girls following the practice. And this is basically through curative and management services. These two functionalities of the health systems are actually supposed to be anchored on the legal and policy documents that are found in the country, or maybe they are also sector specific. And when we talk about sector specific, we are talking about policies that are found in the health sector, in the education sector, and also other sectors that also support the health system. Now, despite the strategic positioning of health system and the existence of these policies and legal documents, we find that Kenya and Nigeria still have substantial level of female genital mutilation, and also female genital mutilation that is also conducted by healthcare providers, and that is what we refer to as medicalisation. Next. Next, please. Now, among some of the legal and policy documents that support the health systems in Kenya, we have a comprehensive document we call the Prohibition of Female Genital Mutilation. And this is an act that was passed in 2011. And apart from that, we also have national-wide policies that do support the work of abandonment of female genital mutilation. And they include the National Policy for Eradication of FGM 2019, the National Policy on School Health, and this is a multi-sector policy involving the education sector and the health sector. And also we have health-specific policy, that is the National Adolescents Sexual and Reproductive Health Policy of 2015. And again, the Ministry of Health has also moved ahead and developed a training manual for healthcare providers in 2007. Of course, it's a bit older, but when you look at Nigeria, Nigeria had a have a comprehensive legal document we refer to as Violence Against Persons Prohibition Act 2015. Apart from that, we have others policies like the National Gender Policy, which has actually been replaced by the National Policy and Policy Action of Elimination of FGM 2013 to 2017. So when you look at these two countries, actually they have very good backing in terms of legal and policy to try. And we have a very good policy legal environment in the two countries, but the question would be, what is happening in terms of the abandonment of FGM? If we have that good environment, why is the levels of FGM still high? Next. Next, please. So, so the two countries have substantial burden of FGM. For example, you're talking of among women who are 15 to 49 years in Kenya, the prevalence is 21%. In Nigeria, the prevalence is 26%. Next. So again, there is substantial medicalisation, that is a practice of FGM by healthcare providers. For example, among the girls who are 0 to 14 years, 20% of them are cut by healthcare providers in Kenya, and 12% are cut by healthcare providers in Nigeria. So this is a good reason why healthcare providers need to come in and try to be in the front line. Next. So the biggest asset that we have in the healthcare system is actually the healthcare providers. And we can leverage on them in terms of addressing FGM. And the reasons being, one, they serve as opinion leaders and role model in the community. So whatever they do can actually attract a lot of premium in terms of people copying them. Secondly, knowledge and skill in whatever they do in other reproductive and medical cases, to try and leverage on that for them to be able to address female genital mutilation complication and sensitize against abandonment of FGM. Next. So we pursued several objectives in understanding how the health sector is responding to prevention and management of FGM. Among them is, we wanted to understand how is health systems supporting prevention of FGM. Second, we wanted to determine the role of healthcare sector in management of FGM and the quality of care offered to clients who have FGM. And the third one, we wanted to identify and recommend some solutions for strengthening the healthcare system to be able to manage and respond to FGM. Second, move on, please. So we adopted a mixed method approach, which was cross-sectional, and we did qualitative study as well as quantitative study in the field, and also we went ahead and analyzed policy documents and legal documents that are found in the two countries. The sites where we executed the field studies were in West Pokot, Kenya, that is a subnational county in Kenya, and also we carried out research in Imo State. And all these revolves around engaging the healthcare providers, the stakeholders, and also assessing the systems, how they are responding to. Are you able to hear me, Chantal? Okay, so what did we find? We found stakeholders had limited knowledge and awareness of legal and policy documents. And these were cross-cutting issues even among the healthcare providers. And the question would be, if the healthcare providers are not aware about the legal and policy documents that speak to the abandonment of FGM, so therefore they cannot be able to execute the functionalities of the health system. The second finding that we we picked was there was lack of guidelines and protocols that could manage FGM complications. And actually, we found that some of the healthcare providers had a lot of difficulties addressing some of the complications. The third one, and also very important, was we didn't find any data that was speaking in terms of how many women were presenting with the complications, how many women were presenting with the cutting. And this was related to the fact that even the tools for correcting that kind of data were not there, and they are not supported by the policies that are there. The other finding that we came across was skills gap among the healthcare providers. They were unable to, they had challenges in providing services, for example, birth for women who presented with the birth complications. Remember, we were conducting research among women who had undergone type 3 FGM. So the ideal procedure would be defibrillation. So healthcare providers told us they were unable to perform defibrillation. The other complication, the other limitation was we found that although women presented with the FGM complications, some of these complications were not addressed. And the challenges were revolving around obstetric complications, psychological complications, and sexual complications. Indeed, most of them even told us, for example, women would present with psychological complications, sexual complications, but they would not do much because they didn't have the training, they didn't have the capacity to help these women. The last and not the least, we found there was limited preventive interventions for FGM. Although we could hear they were doing some outreaches, they were doing some counseling, but some of these, they were not very structured, and they were hampered by inadequate resources. They were hampered by the fact that the tools were not there for them to be supported, and a lot of other issues came up. Next. So what we recommend to strengthen health system, we recommend that policies should be disseminated and implemented. And for them to be disseminated and implemented, one of the things that we noted was lacking were the national plans of actions. So if the health sector can actually accelerate the development of action national plans of action, which can actually give guidance on the way to address the shortcoming, that can actually help. The second recommendation was there is need for integration of FGM into existing health programs, especially the maternal neonatal child health. That way, the implementation can become easier. The third one was we recommend targeted training of healthcare providers, especially in areas where we have high prevalence of FGM. This can actually be an important thing because we can have this recommendation being rolled out and come in to help in those areas. The fourth one was we need to incorporate FGM data in the health management information system, because one of the things we found that this was lacking, and it's not, FGM indicators are not captured in the health management information system. And even when this needs to be incorporated, the good thing is we already have a good discussion with the Ministry of Health, and this is already taking place, and we think this will be a game changer. The last and not the least is there is need to strengthen or even anchor FGM content in the training curriculum for healthcare providers, especially nurses, doctors, and the clinical officers, and also medical assistants in Nigeria, so that as they are being trained in the in-service, they can come up with the skills that can be able to address female genital mutilation. But for the professionals who are already practicing, this can actually be rolled out in form of continuous professional development. Next. Next, please. We are saying health systems in Kenya are actually addressing. So in summary, we are saying health systems in Kenya and Nigeria are responding to FGM, although in an unstructured way, and they face several challenges. And these challenges are in form of policy, capacity, resources, and documentation. Therefore, strengthening response to FGM should involve integration and leveraging on existing health and other sector programs. And through these mechanisms, we can be able to strengthen the health system. Thank you very much, and sorry for the technical disturbance that was there. Thank you.
Thank you very much, Dr. Kamani. If it's possible now, I'd like to turn back to Dr. Agnes Maroka Matua, and we can hear about the legal study.
Thank you very much, Bettina.
So Agnes, I introduced you, and so I'm just going to let you go into your talk.
Is it okay now?
Yes, thank you.
Thank you. The overview of my study, background, I will take you through the background, the objectives, research questions, methodology, findings, and the recommendations. So very quickly on the background, this was a multi-country study conducted in Kenya, Burkina Faso, and Mali. And the reason why we chose these 3 countries is because of the diversity that you can see there, the varying FGM prevalence from 21%, ranging from 21% to 91%. So the 3 countries provide an interesting basis for comparative analysis on how law is used towards abandonment of FGMC in plural legal settings where we have customary law applying in parallel to formal law as well as religious law. Next slide, please. Our research questions were, sorry, there's an echo. Sorry, I'm having some echo on my end. Okay, so the research questions were, how much do citizens obey FGMC laws? And among people who practice FGMC, what are the reasons that motivate them to practice FGMC? And here we were looking at the moral, social, and punitive reasons that motivate them to obey the law, and we compared this with other offenses such as rape and theft. We also looked at the local experience with police and the courts. Next slide, please. Our methodology, we used mixed methods. We had both qualitative and quantitative methods, and we used indirect methods of probing. So for the qualitative work, we carried out focus group discussions where we used the vignettes, sort of short stories, to get to probe indirectly around FGMC. And we also used the list experiments for the quantitative survey. We did an analysis of the laws in Kenya and Burkina Faso and the way in which they are implemented. And we carried out a comparative analysis of the way in which law is used in Kenya and in Burkina Faso. Next slide, please. So how is law used? In all the countries, in Kenya and Burkina Faso, law is used, first of all, by criminalizing FGMC and creating associated offenses as well. So not just procuring FGMC, but other offenses are also established under the law. We also found that law is used to regulate the practices of certain important intervention categories. For example, healthcare providers might be regulated through law. And in Kenya, we also have the Anti-FGM board, as well as law can be used administratively. So those are the three elements in the way in which law might be used. Next slide, please. So what were our findings? Law is important, but in plural legal, law is important, but in the plural legal settings, that plurality should be appreciated. And that basically means that there is conflict sometimes between the various parallel legal systems that might be applying. So for example, we found that people might obey either formal law, and when they're obeying formal law, then they might make a deliberate decision not to obey other systems of law. So law in its totality is important. Secondly, we found that the nature of law affects the behavioral responses to it. So where the law works together, where formal law works hand in hand with customary and religious law, then there is likelihood that it is going to be more effective. However, where there is a conflict between formal law and customary or religious law, this can then limit compliance because individuals and communities are then forced to make a choice between which of the legal systems they are going to obey. Fourthly, we found that the way in which law is administered can promote acceptance of the law at community level. And here we are looking at the coercive use of law, for example, as is done in Kenya versus the persuasive use of law as is done in Burkina Faso. In Kenya, law is used actually in a coercive and sometimes very harsh manner, whereas in Burkina Faso, persuasive authority is used to try and get compliance. For example, therefore, you will find that the courts in Kenya adopt an adversarial system, and that adversarial system leaves very little room for interaction between actually the courts and the community. The end result might be the implementation of law in a very harsh manner that then means communities feel that the law is attacking them and is attacking their culture. By contrast, in Burkina Faso, actually the courts go out of their way to try and talk to individuals to explain to them the harmful effects of FGMC and to try and get their compliance. And this seems to be having a positive effect. Finally, we found that regulation can strengthen other anti-FGM interventions. And here we mean that the work of, say, community health workers, religious leaders, education providers should also be regulated within law so that their interventions are strengthened. This is happening effectively in Burkina Faso, for example, but in Kenya, there is little attention paid to this way in which law can be used. Next slide, please. So given these findings, what are our recommendations broadly? Prohibition through FGM, prohibition of FGMC through criminal law should be complemented through other legal provisions that are not necessarily penal in nature. This could include clearly specified roles for community health workers, schools, religious leaders, and even community leaders. So their roles could be actually specified within the law and also budgetary allocation for them provided for within the law so as to complement the criminal use, the criminalization of FGMC. Involvement of multiple actors such as community leaders, religious leaders within the legal framework for prohibition is important so as to ensure cultural acceptability. So here what we are saying is when we are working in plural legal systems, we must actually take cognizance of that fact and try to incorporate the multiple actors who influence the behavioral choices that people make. So therefore, the law, the formal law, should try to incorporate these particular actors in a manner that then inspires confidence in the law from the community. We are also talking about public awareness campaigns about FGMC and the way in which these are done. There is a variance in the way in which this is done in Kenya and the way in which it is done, say, in Burkina Faso and Mali. In Kenya, public awareness campaigns focus more on instilling fear of punishment and of penal sanctions, as opposed to, say, in Burkina Faso, where public awareness campaigns actually focus on trying to strengthen people's awareness of the law and the fact that actually the law is working to promote the well-being of girls and women. Actually, the effect of the way in which law is used in Burkina Faso is felt in Mali, so that, for instance, in Mali, individuals we found were saying that they believe FGMC is prohibited, even though there is no law prohibiting FGMC in Mali. So it is the spillover effect actually coming through from Burkina Faso and the way in which law is used in Burkina Faso and the public awareness campaigns that happen in Burkina Faso. And we can contrast that. So what we are saying is that awareness campaigns should not focus so much on instilling fear of criminal sanctions as a means of deterring people from practicing FGMC, but instead should focus on using law as a positive way to promote the well-being of girls and women. Continuous generation of data and evidence on how law works to promote abandonment of FGMC is necessary. That is the fourth recommendation that we are making. And here we are learning from the lessons, looking at how law has been used in Kenya, Burkina Faso, and Mali, and the variances, what is coming through. So this type of continued evidence is going to be very useful in influencing policy direction and legislative measures in countries where FGMC is practiced. Next slide, please. So in summary, what we want to emphasize is that law is important in promoting the abandonment of FGMC. However, the effectiveness of law in protecting women and girls from FGMC can be limited by the nature and the content of the law. And also the way in which law is administered and implemented can limit the effectiveness of law. So in order to address this, what we are saying is law can actually be strengthened to contribute more effectively towards the abandonment of FGMC if it is implemented in a manner that does not seem to attack the cultures of practicing communities. Thank you very much. And once again, my apologies for the technical hitches. Thank you.
Thank you very much, Agnes. We are taking questions in the chat box, and technology has not been on our side completely this morning. And so for those who were able to stay with us, we will extend a little bit beyond the hour. And we'll also be making this recording and the PowerPoint presentation available to all attendees. I wanted to follow up from Dr. Kimani's talk to allow some comments from Wisal Ahmad, who is working with WHO. Wisal, are you available?
Yes, thank you, Bettina. Greetings from Geneva, and I hope all you who are attending are keeping safe amidst this pandemic. Dr. Kimani presented a very nice presentation, which is really gives a great segue to a short comment from our end. I'm Wisal Ahmed. I'm a technical officer for WHO headquarters in Geneva. So basically, the scope and scale of FGM services in the health system is dependent on the health system status, its resources, and the FGM country context. And we've seen clearly, like laws, the religious stance, personal beliefs as factors that influence the services. The literature, including Samuel Kimani's study, have shown that healthcare providers, who are the main building blocks of the health system, are not well equipped with knowledge and skills in FGM prevention and care. They are also affected by the social norm and may be supportive or involved in practicing FGM. They, however, if empowered, could be used as effective change agents to stop FGM and provide quality care services. So basically this rationale based from the evidence that's growing is the basis of WHO's health system strengthening approach. So our approach encompasses both normative products and country support activities. Our normative activities include a comprehensive package of tools which target policymakers, program officers, as well as frontline healthcare workers. For example, I'd like to highlight a training manual on person-centered communication for FGM prevention, which is currently under development, but it's what's really innovative about it is that it addresses the aspect of personal beliefs and social norms. Again, I agree with Jacinta, there's no non-standardized approach for not just communities, per person. So every person has their own belief and norm where they're at that need to be addressed at healthcare facilities. Once we test this training package, we will include it in this package as the first evidence-based health sector prevention approach. Another tool that we are quite proud of and we've recently launched is the FGM cost calculator, which targets policymakers and for advocacy. And it's a tool that we use to estimate the current and projected financial healthcare costs associated with FGM. So you could just go into the website and check your country and see how much you could save if you do certain interventions, and could be a great advocacy tool. With regards to the country support activities of this health system strengthening approach that we've initiated in 2018, we engage ministries of health and relevant stakeholders to develop systematic health sector action plans based on the health system strengthening building blocks. And they also include monitoring and evaluation frameworks. I'm seeing in the chat more about measurements. So as WHO, we provide technical and some catalytic funding to support the implementation of these health sector action plans. And it's important to mention that these health sector plans, as Kimani mentioned, are integrated within reproductive, maternal, neonatal, child, and adolescent plans. This approach we are currently implementing in 7 countries, just namely Somalia, Tanzania, Ethiopia, Guinea, Burkina Faso, and Kenya. And they represent different regions, and they do have areas where there is high FGM prevalence. Just wanted to underscore again that our health system strengthening package that contains that training manual is currently under research, and we're testing it. And once we finalize, we'll be happy to share. Thank you for listening. Back to you, over to you.
Thank you very much. Okay, we are still taking questions in our chat box, but in the meantime, I want to turn to our discussant. It's my pleasure to introduce Flavia Mangoita. She joined Equality Now in 2015, and she currently manages the End Harmful Practices program at Equality Now. She's an expert in the field of gender and human rights, and she has an accomplished career devoted to human rights promotion and protection throughout the African continent. Welcome, Flavia.
Thank you so much for the introduction. I assume I still have 5 minutes, though I can see we're just about the top of the hour, but I'll just quickly dive into it. It's been wonderful to listen to all the presenters and to just hear the insights from the research, the technological challenges notwithstanding. So for my end, I'll just be sharing some perspectives in terms of what comes to mind, or some additional thoughts that we could consider as we go along. And just the first thing is to say thank you very much to Population Council and other institutions that are investing in data and building evidence, because those of us who work in advocacy and who are trying to especially work on legal and policy advocacy, it's a very critical tool for us to enable us to really guide our thinking and to nuance what we're recommending and what we're advocating for. So the first point that I'd like to maybe say, or rather in response to all that I've heard, is that I think it's critical to also underscore that FGM is global. By this, I mean that there's really beyond the countries where we have national prevalence data, there are so many other countries that we are coming to also slowly, that are coming to light that this is indeed an issue. Recently, Equality Now, together with partners, the End FGM European Network and the US End FGM Network, put together a report that tries to highlight the global nature of this issue, this issue that we're calling female genital mutilation. So we are seeing that it's about in 92 countries at least where we have some sort of information data, be it national prevalence data or small-scale research or anecdotal information or indirect estimates that indicate to this issue. The push for me, or rather the request or the thinking that I would like to advance, is that there's really need for further investments in generating data, both national prevalence data where we do not have it, and also subnational data that Jacinta very well articulated, especially where we already have national prevalence data that's existing. It's good to really take the second layer. And just touching on that, we have, for example, in Asia, where we have countries that have such high prevalence of FGM, but we do not, unfortunately, have national prevalence data. So this is very important. It helps us to really direct our advocacy, as it were. Just touching a bit on the issue around the subnational data and the issue around hotspots and prioritizing areas where the issue is really advanced. I think, for example, in Kenya, where we mentioned hotspots, we have the 22 counties, for example, that have been highlighted as being the problem areas. I think it's also important to interrogate that, because most of this, we are taking an approach that is more like looking at the ethnic groups of the FGM, but I think with internal migration within a country, I think it's important to also look at it from the county perspective, just to look at where are people moving to, where are these practicing communities moving to, both within the national level and also outside within Africa, where our community is moving to in this era of globalization. So I think that's something that is also important to capture. So basically the recommendation is that as we continue doing this work, I think it's important to continue investing in research programs that enable us to really canvass the whole globe and be able to respond to this, especially if you're going to realize the SDGs. My second point is really around also nuancing and contextualizing, the importance of research and evidence in contextualizing and nuancing the laws, just in response to the presentation on the laws. So for example, if we have information that medicalisation is an issue or cross-border FGM is an issue within a context, really this information helps us to really package the legal framework so that it's responding to the contextual realities of the country. So for example, Burkina Faso is landlocked, surrounded by 5 countries, very robust legislation. Implementation is really one that is to be applauded. But what is happening across the borders? What extent do the laws that we are advocating for or within those countries, are they responding to this phenomenon of cross-border FGM? So in terms of effectiveness of the laws, just responding to some of the points that Agnes raised, I think indeed, I think we acknowledge to a certain extent that the law is at a minimum an indicator of political will or a signal that the practice is rejected. So it's basically a step towards getting us there. And what we're seeing around the world where we are working in the different countries, there is a broad spectrum of approaches that states are taking in terms of legislating. On one hand, you have the ideal. We're calling them the ideal because it's really, as Agnes has demonstrated, that it's a law that is covering criminalization, it's covering regulation, it's covering administration. But not many countries are taking that approach. So you have that on one hand. On the other hand, you have countries where the criminal provision is within the penal code. So it's a very limited way of looking at the issue. So it's a criminalization of the issue. And then on the other hand, you even have on the other end of the spectrum countries where they are using other provisions in legislation such as assault, injury, etc., to address the issue of FGM. So we may not have the privilege or luxury of picking and choosing what country does what. We can only recommend that the country takes a more comprehensive approach to legislating on FGM. But even when they opt for provisions within the penal code, for example, Sudan is one of the recent cases that we are celebrating in that regard. What we need to really push countries to invest comprehensively in other measures that enable the country to respond to FGM, not just from a criminalization perspective, but to ensure that we have robust public awareness campaigns, etc. For example, in Sudan, there's a whole broad backdrop of gender inequality, discrimination, and the role of the women's groups in that country for pushing for gender equality. So I think it's really important that we look at that advancement in criminalizing FGM within the broader backdrop of gender inequality or the efforts that we're making to achieve gender equality. So as I conclude, I think most of the things that I wanted to say have really been touched on, but some of the I'll just try and emphasize on 2 points. I think the process of making laws, of coming up with laws, is very critical. To what extent are they human rights? Are we using a human rights-based approach to lawmaking? How are we communicating the importance of laws to communities? How is the messaging? How is it being packaged? Are we working with the public in terms of them seeing the necessity of these laws? And the criminalization is indeed critical because we are saying that FGM is a violation of human rights, it's violence against women. But that's not the only piece. We really need to invest in other aspects that will enable us to see sustainable change. And then a legislative interpretation is something that is very critical, especially in the context of Kenya, where we have a very robust law. We are seeing, unfortunately, that most of the stakeholders, be it prosecutors, law enforcement, etc., may not necessarily understand, including medical or personnel, healthcare providers, to what extent are actors and duty bearers, especially understanding the provisions of the laws. What do the offenses mean? What does aiding and abetting mean? What does failure to report mean? To what extent are we investing in capacity for these various actors to be able to know and apply the law, both not in terms of the content, but also the intent. What was the intent or the spirit of the legislation? In Kenya, unfortunately, we have situations where women have been re-victimized, women who have undergone the cut, and girls have found themselves at loggerheads with the law. I do not think that is the intent and the spirit of the legislation. So I think it's important that all of us across the board invest in the capacity of the various actors, especially the duty bearers, to understand the provisions in the law, especially in contexts where we have very broad, very comprehensive laws, so that they're able to apply them both in terms of the content that is there and also the spirit. Lastly, I think it's important to invest in, we are talking about multi-sectoral responses. Those are really good, and it's something that we're really pushing for as equality now. But to what extent are we also coordinating the various actors who are around the table? To what extent is there adequate coordination between law enforcement, health sector, education, etc.? So I think that's why in some contexts, they can see that in Kenya and Burkina Faso, we have the anti-FGM board in Kenya, and in Burkina Faso, we have the national committee. We need to resource them. We need to really build their capacity to be able to coordinate them and trigger the various multi-sectoral responses that are needed in order to really have an investment in ending FGM that is not really focused purely on criminalization, but really also looks at all the other aspects that were intended in the law. So I think because of time, I'll stop there, but those are some of the reflections that I have to share at this point. Thank you very much.
Thank you, Flavia. Your comments about the role of the law and the potential roles of the law reflect several of the questions that came up in the group chat, in particular the distinction between regulation versus criminalization, and whether success of a legal reform strategy ought to be quantified by the number of convictions. I'm going to let Agnes reply, given if her internet.
Thank you, Bettina. Can you hear me?
Yes.
Yes, so I think those are really important questions, and from discussions that we've been having on the ground in Kenya with stakeholders, in particular in the legal sector, when we talk about criminalization, we basically mean, you know, the use of criminal law to try and act as a deterrent measure, so that communities and individuals perhaps respond to the law by changing their behavior because they want to avoid penal sanctions, they want to avoid going to jail, they want to avoid a fine. But while in Kenya that has been used in a very robust way, the number of convictions has actually not been very high. Actually, 28 too many and UNICEF UNFPA joint program both report quite low numbers, as at 2016 and 2018, the law having been passed in 2011. So we haven't even gotten up to 100 prosecutions yet. When we talk about regulation, what we mean is law can actually be used to support interventions by community health workers, and how so? Clearly providing within the law what community health workers should be doing towards the abandonment of FGMC. That in itself actually creates obligations, so that community health workers are required, for instance, to go out and have discussions with communities. They're supposed to develop indicators, and that is something that can be provided for within the law by using regulation. And the beauty with regulation is that it also then requires governments to invest, to make budgetary allocation for those types of interventions, so that they just don't fall through the cracks. And it goes beyond just the use of policy. And now it is actually embedded in the law. Therefore, people know that if I am a community health worker, if I am running a school, I have certain obligations that I am required to discharge. And if I do not discharge them, then, you know, I will be failing in my duty under the law, even if it is not to face criminal sanctions, but questions will be raised and I will have to respond to them. Again, when we talk about regulation, we can say, what is the role of schools? In Kenya, the issue has come up so that, for instance, we are asking, what responsibility do schools have to protect girls who have undergone FGM? Should they be expelled from school? Because we had such a case where 49 girls were actually facing expulsion from school because they underwent FGMC contrary to the rules and the regulations and the guidelines of the school in which they were enrolled. So when we talk about regulation, we will be saying that as schools, you're important institutions that protect girls from FGMC, but can you expel? Should you remove girls from this school if they have undergone FGM, knowing that they will probably be exposed to, say, early and forced marriage? So beyond just the use of policy, when we have these issues put in the law very clearly, then people know that they have obligations, and there are certain measures that they need to take in order to meet those obligations. And budgetary allocation is also required in order to make it work. And in Kenya, we have the Anti-FGM Board. The challenge is the Anti-FGM Board is one institution, and it is actually a national level institution. We do not know exactly how the work of the Anti-FGM Board is to be devolved at county level, how the budgetary organization should work at that level, and exactly how to bring in the other actors, the schools, the religious leaders, the community leaders. What is their role? What is the role of the churches and the mosques? When we are talking about FGM, is it simply out of their goodwill, or should they actually have certain obligations and roles spelled out for them? Should governments invest in training for them? Should governments invest in capacity building for these other actors, so that there is a multi-sectoral response towards the abandonment of FGMC. And that is another potential that law then has beyond criminalization. Thank you very much, Bettina. And Flavia, thank you.
Thank you, Agnes. I believe we're coming to the end of our time for this webinar. This has started many conversations that I think are going to be continuing in many different forms following today's presentation. I want to remind everybody that we have our second webinar 1 week from tomorrow at 4:00 p.m. East African time, and that's going to be on understanding what, where, and why the practice of FGMC continues. There's a great deal more of rich research to share and many other conversations to continue. And I invite all of you to participate in this lively exchange. Jacinta, do you have any final remarks?
Just following on you, Bettina, I just want to thank everyone for spending time with us today and for the very useful insights we've received. And yes, I think many of these conversations are going to continue. So I just want to say thank you very much to everyone again.
Okay, thank you, everyone. We will send the presentation and relevance technical reports and briefs out. I wish you all a good day, a good evening, and as Bettina said, but just to correct, our next webinar will be on next Friday, the May 22nd, the same time. Thank you.
Thank you, Chantal.
Chantal, the meeting recording is also available, so if you need it, I can forward it to you.